Hi, my name's Danielle Burney. I'm a student at Franklin University in the FNP program. I'm going to do my presentation on impetigo. Impetigo is a highly contagious bacterial infection, most commonly found in children ages 2 to 5, but can be found in older children and adults as well. Often caused by the bacteria Staphylococcus, but can also be caused by Streptococcus bacteria. Risk factors for impetigo include close contact with others infected, such as kids in daycare, when they share toys, things like that, warm and humid climates, people in poverty, poor hygiene, crowding, broken skin, underlying scabies, and also people that are immunocompromised. The clinical presentation of this includes red sores around the nose and mouth, which you can see right here, quickly rupture, and they form these honey-colored crusts, which is like the gold standard of diagnosis. They can also be found on other parts of the body. Kids like to touch their mouth, hands, face, extremities. So that's how it spreads in close contact, touching, clothing, towels, and they might report like a little bit of itching and soreness with the lesions. Here's a couple more examples of impetigo, especially with people with different skin colors. You can see them on the face here. These vesicles and papules rupture really quickly and can cause this honey-crusted around the face and hands, and then that's how it spreads, which is how you see it here on the hands, by touching the face or by close contact, others, or sharing things like towels, clothing, anything like that. Diagnostics for impetigo is typically just made on clinical presentation. You can do a gram stain after like shaving the pus or culture, especially if it's not responding to treatment initially, but typically just made based on clinical presentation. No routine labs or imaging are indicated. Topical treatment is considered the first line treatment if there's a limited number of lesions. Mupirocin 3 times a day for 5 days is recommended. There are benefits to choosing topical treatment if indicated and not as more widespread. So there are fewer side effects and it is less likely to contribute to antibiotic resistance, which we'll actually talk about later. Over-the-counter meds such as bacitracin are actually not recommended in the treatment and do not replace the antibiotic topical therapy prescription. And then if it is more widespread or there are more lesions, oral antibiotics such as cephalexin and dicloxacillin are recommended treatment. Patient education and parent teaching is very important here. We want to avoid touching the face, scratching the lesions, and we want to wash our hands frequently. If a sink's not available, hand sanitizer works great. Not sharing personal items, especially for toys, towels, stuff like that, where kids can spread this very easily. Want to keep the nails short, especially for little kids, because they can scratch and maybe spread this further. They can return to school or adults return to work after 24 hours of treatment. If there are sores, they should be covered with bandages, especially if there's pus or exudate, until it's healed. And then we want to make sure that we're teaching to finish the entire course of antibiotics or that the recommended treatment for topical therapy is completed as well. A few common differentials that I found that could be very similar to impetigo would be SSSS, which is staphylococcal scalded skin syndrome. It's just more of a widespread infection, but this kid right here, you can actually see it does have SSSS, which looks very similar to impetigo. It does typically require hospitalization and IV antibiotics, so definitely a much stronger infection than the impetigo. And then another systemic infection would be varicella, which is also known as chickenpox. Chickenpox presents as rash, headache, fever, fatigue, loss of appetite. This kid here in the photo, you can see more of a widespread rash, but does still have that rash around the face. Could present as that and often be confused as impetigo. And we talked about concerns for antibiotic resistance in an earlier slide, but just choosing a topical antibiotic, if possible, gives you a chance of less resistance. If it is a MRSA, it may require different antibiotics, which are often very resistant. And then if not better in 2 to 3 days, we should consider a different treatment option, and we could culture the lesions as well to make sure that we're choosing the best treatment. Patient impact could be a cosmetic appearance. It may cause embarrassment. It's not chronic, and it shouldn't really leave any scarring. Kids or adults can miss work or school. And this can cause some anxiety if it is recurring, especially for parents and kids in daycare. Alternative home options, remedies, not really considered replacement therapy, maybe adjunct, a few things like aloe vera, garlic, ginger, but they definitely do not replace the antibiotic therapy. If the infection improves after initial treatment, there's really no follow-up indicated. If it doesn't improve after about 3 days, 2 to 3 days, we would want them to come back into the office. At this point, you could culture the lesions if you have not yet, and then we want to be aware if a fever develops, pain or swelling, warmth around the lesions, to make sure that we're choosing the best treatment and that it doesn't progress into something more severe. And this is my references page. Thank you so much for listening to my presentation on impetigo.